Thank you for joining this episode of UAB Medicine's Post-COVID Lunch and Learn series. Today, Dr. Stuart Cohen, Chief of UAB Primary Care, will be presenting Post-COVID Syndrome and Your Primary Care Provider. Please submit your questions in the Q&A, and if time allows at the end of today's presentation, Dr. Cohen will try and answer as many questions as possible. For those of you new to Zoom, you will find the Q&A button at the bottom of your Zoom window. I will pass this over to Dr. Cohen. Dr. Cohen?
Thank you, Laura. I want to first say thank you. I'm happy to be here today. Again, I'm Dr. Stuart Cohen. I'm a general internist, and I've been with UAB now for a little over 20 years, currently serving as the Chief of UAB Prime Care. For those of you who have been participating in the post-COVID webinar series, welcome back. For those of you who are new, glad that you are with us. Today is the 9th discussion of post-COVID, and I will be, in a sense, anchoring this series. For the first 8 talks before me, you've heard from different subspecialists who've been addressing specific aspects of post-COVID syndrome related to given disease processes or specific organ systems. My goal today is going to be to sort of back up and take a little broader picture to review a little bit about COVID and what post-COVID is, and then speak towards what you could expect your primary care doctor to sort of do or evaluate if you were to present with post-COVID symptoms. And then to speak about when referral to one of our specialists may be indicated. So I'd like to start with a general overview. And to start with, what is a coronavirus? Well, the virus which causes COVID-19 is the SARS-CoV-2 virus. It's really a group of viruses which have been with us for really millennial. It infects mammals and birds and is known to be the common cause of up to 15 to 20% of our typical winter colds, coronaviruses themselves. The SARS-CoV-2 is a newer variant of a coronavirus, which obviously causes COVID-19. It gets its name from the spike protein on the envelope of the coronavirus, which can look like a crown, and crown in Latin is corona. So that's where the name comes from. Important to realize that this is a very, very infectious virus. And for many of you who are aware of what's going on now in not only the country, but our state, but we now have this Delta variant, which is the newest variant of the SARS-CoV-2 virus. And it is significantly more infectious than what we had seen previously. It has recently been likened to being as infectious as chickenpox. And I think many of you sort of understand what that means. Just being in the room for a very limited amount of time can lead to infection. So important to know that. Well, who is at most risk for developing COVID-19? Certainly anyone who is 65 or older is felt to be at risk, those living in nursing homes or skilled nursing facility, and then anyone who has underlying chronic conditions that affect a given organ system. For example, those with chronic lung disease, chronic liver disease, kidney disease, cerebrovascular disease. However, there are also just some more generalized disease processes that many folks have, such as hypertension or diabetes, which also confer pretty significant risk. Interestingly, just obesity alone, without having any other chronic illnesses, has also been shown to be a major risk factor for developing, worse outcomes if one were to develop COVID. And then those who are immunosuppressed, whether it be due to medications, which one might be taking because of an underlying rheumatologic condition, or possibly if someone has cancer or is on medications related to cancer therapy, all put people at significant risk for severe infections with COVID. Well, what are the common symptoms of acute COVID? And they really are quite similar to what we might think of as a typical upper respiratory tract illness, or even more like a flu-like illness. By that, people oftentimes present with fever. They sometimes will have evidence of ongoing cough, nasal congestion. They may or may not have some shortness of breath associated with that, and typically just feel like they've been run over by a Mack truck. So a sense of muscle sort of pain, joint discomfort is very commonly described as well. Less frequently, but we can see evidence of some GI symptoms, some nausea, vomiting, diarrhea that can go along with acute COVID as well. Something that is unique for a viral process for a URI type symptom is the loss of sense of smell and taste. So in those individuals who have upper respiratory type symptoms and a loss of smell or taste, that's really a good sign or a telling sign that they very well might have COVID. Now, one can present with difficulty with smell and taste with simply a sinus infection in and of itself, but certainly if there's more of a generalized illness, then typically that would be COVID, or we would think we would be very concerned that it could be COVID. What can we expect from the recovery from acute COVID? Well known that patients who are sicker, so those who require hospitalization and or time in the intensive care unit, that those patients are more likely to have prolonged symptoms that can last for many weeks, if not many months. The average recovery time is probably in the order of 4 to 6 weeks, although I'm sure all of us know of individuals who developed COVID, had relatively mild symptoms, and may be back to their normal self even within 10 to 14 days. Very important to realize that most people fully recover from their initial bout of COVID without any long-term symptoms. Now, the focus of this webinar, the focus of my talk is on sort of post-COVID symptoms. But again, that is certainly a minority of patients who go on to develop prolonged symptoms. So what is post-COVID? When we first develop COVID or are infected with the SARS-CoV-2 virus, any symptoms lasting up to about 4 weeks we consider an acute process. There's a bit of a gray area where if you're persisting beyond 4 weeks, 4 to 12 weeks, that we don't classify it as post-COVID, but more of ongoing symptomatic COVID. However, once someone has symptoms that are persisting or that develop after 12 weeks, that's the situation that we begin to use the term post-COVID-19. Other terms that you might hear is post-acute COVID syndrome, long haulers, long-term COVID, lots of different ways of really naming the same process. Now, a couple of things to realize about post-COVID is that for many individuals, it's simply a persistence of the symptoms that they had acutely, right? So you get infected, you have a set of symptoms, maybe significant difficulties with cough or shortness of breath that persist beyond 12 weeks. But we also understand that it's not unusual for people to develop new symptoms, potentially symptoms that they did not have acutely, but develop later, that we do believe is a reflection of COVID as well. Important to understand that these symptoms, though, need to not be explained by other diagnoses. And one of the key functions of your primary doctor is to really assess for any other non-COVID related illness which may be causing the symptoms that are bringing you to their office at that date. Well, how many people develop post-COVID syndrome? And as you can see from this slide, in the literature, there's a large variability as to what that prevalence may or may not be, anywhere from 5 to 80%. That really is, we see such a large range because of the different methodologies used to assess this. I think our best estimate, though, is something more on the order of 15 to 30% of individuals who have ongoing symptoms or new symptoms beyond a 12-week period. Well, what causes post-COVID syndrome? And again, here, the jury's really out. There are really many different theories. None of them have been proven. And in all likelihood, it's probably not caused by one specific process, but potentially could be a number of different processes that could be occurring for different individuals. I think well accepted that there is probably a component of post-COVID syndrome or symptoms that are related to sort of the initial organ damage from the acute infection. Someone became infected. There were sort of damage that occurred at the time of the illness, and their symptoms are simply persisting beyond 12 weeks. But another theory that has gotten a lot of attention, which is likely at play, is this notion of a post-infectious hyperinflammatory process. All big words, but what this entails is the notion that someone became infected with COVID, our body's natural immune response revs up and we clear the virus, and it's actually ongoing inflammation or our body's own inflammatory cells which are causing the ongoing damage. So it's not that there's ongoing virus in this theory, it's the fact that it's our own body's immune system, which is now in a sense attacking itself, which is causing the post-COVID symptoms. It is thought that probably for some people, maybe a minority, that there could be ongoing low-grade viral infection. So the idea here is that our body has not adequately cleared the virus and that there are pools or reservoirs of virus that are persisting that can lead to ongoing issues and problems, likely due to a poor antibody response. And last, this notion of post-viral fatigue. Well known in other viral processes and other entities prior to COVID that in certain individuals who develop viral infections, that they can have ongoing symptoms that persist beyond the acute infection. A process that you may have heard of is something called an entity called chronic fatigue syndrome. It is now actually called myalgic encephalopathy / chronic fatigue syndrome. But again, this is an entity not related to COVID, but seen with other viral processes in which ongoing persistent fatigue, malaise, muscle issues can persist. And a lot of how we are approaching post-COVID is using our understanding of what has been helpful in treating people with chronic fatigue syndrome. Well, what are the common post-COVID symptoms? So now we're sort of moving away from acute COVID and thinking more about people who are presenting, again, 12 weeks or more later with ongoing symptoms. And they're a little different than what we see with acute COVID. The most common being fatigue, malaise, difficulty at times with sort of thinking clearly, the so-called brain fog, which has been discussed, I think, in previous talks, is very common. There can be some ongoing breathing issues, pulmonary or respiratory issues, and chest pain. But other processes that we see is not only the brain fog, but difficulty sleeping, so-called COVID-somnia is very common. We will see patients who report very rapid heart rate with position changes, a sense of palpitations, dizziness upon standing. These are all fairly common symptoms of post-COVID. There are also many psychological or cognitive symptoms that persist, certainly difficulty with anxiety, depression, memory issues, and certainly for those individuals who have been hospitalized and or in the intensive care, a sense of post-traumatic stress or post-traumatic anxiety persists. Well, what can you expect if you present to your primary doctor as far as sort of initial diagnosis and testing for post-COVID? So what does the workup look like? It really starts with a detailed history, as most of sort of visits to a physician does. And I think your doctor needs to initially ascertain, did you actually have COVID, yes or no? Did you have a positive COVID test? How was it diagnosed? And then have an understanding of the severity of the illness initially, right? So how sick did one get with their initial COVID? Did they require hospitalization? What were the major organ systems or symptoms that were affected initially? Second, really need to have an understanding of the past medical history, right? So does someone have ongoing chronic disease, chronic illness, underlying obstructive pulmonary disease or underlying heart disease, for example, prior to COVID? Because again, well known that COVID can exacerbate those ongoing, chronic conditions that they may have had beforehand. It's also vital that your doctor understands a little more about your sort of social support at home. Is someone currently employed? If they have been employed, are their symptoms so severe now that it's making it difficult for them to maintain employment? Where do they live? Do they have a support structure in their house? Do they have family members or loved ones who can take care of them? Do they have access to food? I mean, these are all really important questions to ask because based on the answers to these questions, right, your physician may be able to, harness other support and other factors that can help a given individual sort of work their way through their post-COVID state. Also important to understand what's a person's current activity of daily living, right? Can they feed themselves? Can they bathe themselves and such? And that's important because it really also is an indication of frailty and a sense of sort of how tenuous is a person and how severe are their symptoms currently. We then move on to the physical exam, and we really can't ignore basic vital signs. They give us a lot of information as to the severity of one's illness. So what is one's heart rate? What's their respiratory rate? What is their blood pressure? And also the oxygen level. Oxygen level becomes a key indicator for COVID, as I think all of you know that COVID, as a primarily an acute respiratory process, can affect the lungs. So just getting a simple oxygen meter that I'm sure all of you have now seen that you can sort of wear on your finger, put on your finger to measure a level. And we want those oxygen levels to be greater than 93% or more. They don't have to be 100%, but when they're getting down below 93%, then that is considered abnormal. And certainly unless someone had underlying cardiac or pulmonary symptoms, that would be unusual to have an oxygen level lower than 93%. Next, on the physical exam, obviously listening to the heart and lungs, a basic exam is going to be important, but then a more thorough exam based on the symptoms that a patient presents with. As an example, if someone presented with significant, weakness and they were having even difficulty walking, then doing a really thorough neurologic exam where they're assessing not only what are known as the cranial nerves, but one's strength, reflexes, and such would be important. There are a few simple tests that can be done in your doctor's office. Certainly, if the symptoms are that of significant fatigue with even minimal activity, then checking that oxygen level, not just sitting, but getting up, walking someone up and down the hallways can be really helpful and provide valuable information to know, how they respond to even minimal exercise. If a patient's presenting with significant sort of dizziness or palpitations with position change, then doing a set of what are known as orthostatic vital signs can be helpful. And that's where one is checking the blood pressure and heart rate, initially lying down and then having a patient sit and then eventually stand and monitor with each of those positional changes what their vital signs are. And if there's a significant drop in the blood pressure or increase in the heart rate, then those are important findings that I think would help your doctor understand a little bit more about what may be going on. Important to note that there is absolutely no single laboratory test that can be obtained that is going to sort of make the diagnosis of post-COVID. And in fact, what your doctor is really trying to do is to assess for other non-COVID related illnesses that may be presenting in a similar fashion. Now, what labs are obtained or what imaging is obtained really is solely dependent upon the individual patient's history, what you find on physical exam, and really what their sort of clinical symptoms are. At times, very little testing is needed. At other times, there would be a more advanced testing that would likely be obtained. So again, just to repeat, your doctor their sense is this a non-COVID related illness, which they would want to diagnose and then potentially have treatment for. Understanding a past medical history. So is this a previous disorder or entity that you had, disease that one had that's been made worse by COVID, or is this true sort of post-COVID syndrome and the presentation is simply related to the previous COVID diagnosis? Now, once your doctor obtains the basic labs and possibly some basic imaging, it is not at all uncommon for the testing to be normal in post-COVID syndrome. But it's really important to understand that the absence of any specific abnormalities in no way means that one doesn't have post-COVID syndrome. And it should in no way sort of dismiss the impact of the patient's illness, on how it's affecting them, on their quality of life, on their activities of daily living. So I've heard from patients before say, well, we've obtained testing and now everything's negative, so that means I'm okay. And the answer is not necessarily. It just means that we've not noted significant abnormalities. But again, it does not diminish the fact that post-COVID is a real syndrome and that the symptoms can be really quite devastating. So what are some of the basic labs that might be considered sort of routine, if you will, by your primary doc? Certainly looking at basic blood counts. What is your white blood cell count? Is there evidence of anemia by checking your red blood cell counts? Basic electrolytes, sodium, potassium levels, and such. Looking at kidney function and liver functions. I think those would all be pretty standard things that I would expect your doctor to obtain. Inflammatory markers are often checked in this setting, despite the fact that in post-COVID syndrome, most of the time, the inflammatory markers will be normal, even in situations where we might think that a post-inflammatory process is the underlying etiology or cause of the post-COVID state. Thyroid functions would oftentimes be obtained, not so much because post-COVID syndrome causes thyroid abnormalities, but because thyroid disorders are pretty common in the general population, and either a low or a high thyroid state can present with very similar symptoms as post-COVID symptoms. Likewise, vitamin levels such as vitamin B12, possibly vitamin D, is oftentimes obtained, in part because if they're found to be low, then replacement is a pretty easy thing to do, and it's very low risk. Now, there are more specialized testing that oftentimes will be obtained. Certainly if one's presenting with really bad muscle aches, joint pains, maybe with, again, sort of a general sense of malaise, thinking in terms of some of the more systemic rheumatologic conditions, such as rheumatoid arthritis or lupus, or some of the inflammatory myopathies would be something your doctor might consider, with specific testing geared towards those. It is well known that COVID and acute COVID can lead to some clotting disorders, where one's blood is actually more likely to clot. So there are instances where obtaining some blood clotting tests would be useful. I think anyone presenting with chest pain, or certainly discomfort in the chest area with exertion, getting some simple blood work to assess for cardiac enzyme, something called a serum troponin, would likely be obtained. And then there's a test that can be checked in the blood that can sometimes differentiate if one is having shortness of breath, whether it could be more related to the heart or more related to the lungs. When we think about imaging, right, so there's a whole set of tests that would be potentially obtained, again, depending upon one's given symptoms. I think most individuals, if they came in with cough, shortness of breath, a chest x-ray would be pretty commonly done. Now, whether other testing such as pulmonary function studies or CAT scans of the lungs were obtained, I think would really depend upon not only your symptoms, but also how comfortable your primary care doctor might be with interpreting these studies. Certainly, if someone has chest pains, ongoing palpitations, a basic echocardiogram, which is an ultrasound of the heart, is something that I think would not be unreasonable for your primary doctor to obtain. And if there were abnormalities, that would then potentially prompt referral to the cardiologist. Relative to GI symptoms, such as abdominal pain, nausea, or diarrhea, there's probably a limited role for imaging for the abdominal issues. If there's significant pain associated in the upper abdomen, maybe an ultrasound or a CAT scan. If the problems are more nausea, diarrhea, then frequently you really need more advanced testing, such as an endoscopy of either the upper endoscopy looking at the esophagus and the stomach, or colonoscopy where you're looking at the colon. But those tests certainly require referral to a GI specialist. For sort of headache, if someone has ongoing persistent headache, imaging of the brain, I think would be reasonable with something such as a head CT. If someone's having ongoing muscle weakness, numbness, tingling in their arms or legs, there are more specific studies, what's known as an encephalomyelogram and nerve conduction velocity tests that can be obtained. However, those tests would typically be done more by a neurologist as opposed to your specialist. And certainly when it comes to some of the more psychological issues of COVID, such as depression, anxiety, there's a whole host of surveys and questionnaires that your doctor may use to help better define what the issues are, but also better understand the severity and the effect on one's quality of life. Well, that takes me to managing post-COVID syndrome. So what do we do to treat post-COVID syndrome? And unfortunately, given sort of the post-COVID symptoms, post-COVID syndrome is such a varied illness that there's really no sort of single approach to management. There's no magic pill that can be obtained, that can be provided to necessarily cure what ails you. But the goal becomes to really optimize one's quality of life, optimize one's function, and setting goals with your provider becomes key to doing that. So I think by setting those goals and expectations, it becomes important to sort of gauge sort of the type of improvement and to understand the timeline for improvement for a given individual. Now, for a given set of symptoms, there are some tools, if you will, or some treatments that have been shown to be effective. And one of those is breathing exercises. So for those individuals who have ongoing difficulty with breathing, some shortness of breath, some home exercises, which one can teach themselves, have really been shown to be helpful. And at the end of my talk, I have some links and that one could go to that could show one how to perform these breathing exercises on their own. I had mentioned fatigue after minimal exertion. There's actually a medical term for this called post-exertional malaise. And what we've learned in part through our understanding of chronic fatigue syndrome is that telling someone just to go out there and exercise and you'll feel better with exercise is probably not very helpful and could be harmful. So there's this notion of graduated exercise, which really means you have to sort of first determine what one's activity level is now, what is the amount of activity that brings on significant fatigue. And the idea is to sort of begin to gradually increase one's exercise, really quite slowly over time. And again, I have included a link at the end of my talk that is at least a handout that can help people begin to initiate graduated exercise. But the notion that one should just go out there and exercise through their discomfort and their fatigue probably can make things worse. Now, if smell and or taste remains a major concern, the loss of that, there are things that we can do to help retrain our sense of smell. For those of you who saw Dr. Cho's presentation on smell, he went over this in some detail. And I've actually also included a link that actually is directly to a piece that he did for one of our local TV stations, where he sort of showed individuals how they can begin to, retrain their sense of smell themselves. For individuals who have ongoing anxiety, depression, potentially post-traumatic stress, counseling really can be helpful. So again, speaking to your provider, potentially making a referral to a trained counselor in cognitive behavioral therapy can be quite helpful. And then there are certainly instances in which more formal, whether it be physical, occupational, speech, or vocational therapy may be indicated and quite helpful. And that's really would depend upon a patient's sort of specific set of symptoms. Now, I can't stress enough how important sleep and a healthy diet is. Certainly a diet's important, but sleep is so important as well. And in patients who are having significant difficulty with sleep, I mean, through counseling, that can be helpful as well. I've also attached a link at the end of this talk on sort of healthy sleep habits that can help people, potentially get over the difficulty of it with insomnia, which they may have related to COVID. I have placed here on the slide a limited role for medications. Now, certainly the medications, there's no specific medication that can be used, but there are over-the-counter medicines for, muscle aches, discomfort, over-the-counter medications for nausea and such, which there's certainly a role for. But I think there's probably a limited role for prescription medications and certainly a limited role for prescription pain medications. So something just to be aware of, and I would say to caution against sort of thinking that we can sort of medicate our way through many of these symptoms. Well, when do we consider referral to a specialist? I think certainly if there's evidence of organ damage on the initial laboratory testing or initial imaging or studies, then that's probably a pretty good reason to consider referring to a specialist. As I've mentioned before, though, quite often patients who have ongoing post-COVID symptoms, the laboratory data is normal, and many of the imaging studies and more advanced studies are also don't show any specific abnormalities. Another time where I think referral to specialists would be reasonable would be when, one's done the initial lab work and or studies and they're unrevealing. But the symptoms that the patient presents with is just not totally compatible with post-COVID syndrome. So if your doctor has unease or doesn't feel comfortable that they really understand what's going on, and certainly if someone's symptoms are, relate to a specific organ system, a referral to, for example, a pulmonologist or a cardiologist, certainly may be beneficial in that scenario. And then last, but probably this is the most common cause of time when we would refer to a specialist, is if, despite conservative therapy, patients' symptoms are worsening. And this speaks to the importance of having an ongoing relationship with your primary doc, letting him or her know how you are feeling over time. Because again, time is helpful, well known. We believe that most individuals, even with post-COVID symptoms, will eventually improve with time. But if those symptoms are worsening, you don't want to suffer out there alone and just sort of say, well, geez, there's nothing that can be done. That needs to be brought to the attention of your primary doc, and that's a situation that I could imagine potential referral to specialty care would be warranted. I want to speak a little on self-management because I do think there's a lot that an individual can do to really try to help them improve with their symptoms and get well, if you will. This notion of stepwise goals is important. Sort of an appropriate expectation is key. If an individual thinks that they can or should be able to get back to their life, pre-COVID within a week or two, it very well might be unrealistic depending upon how one is feeling. So again, setting sort of small goals, small steps that hopefully can be obtainable is really important. Keeping a record of the changes in your symptoms is also very important. Just the act of sort of jotting down how one is feeling on a daily basis or every couple of days really can show individuals that over time they find that they're really doing a good bit better, over the course of several weeks. But it's also an opportunity to potentially reveal that someone is not doing better and potentially worse, and then you would want to bring that to the attention of your provider. I've mentioned sleep. I've mentioned a healthful diet. I've mentioned sort of making sure that you have close follow up and contact with your physician. I think it's really important to sort of state and for us to all to understand that this is still a very new disease, and our understanding not only of acute COVID, but post-COVID, maybe even more so, we're really in our infancy here. And my expectation is that as we continue to learn more, that we have a better understanding of not only the underlying physiology or the pathophysiology of post-COVID, but also have a better understanding of how best to treat it. So again, keeping in touch with your doctor will be essential as new treatments evolve. You certainly would want to be able to take advantage of that. Last point I mentioned here is to join a support group. I do think that support groups for entities such as post-COVID can be really, really helpful. I think oftentimes people feel alone out there. They feel as if they're the only ones going through sort of their set of symptoms, which are lasting now longer than they might expect. So support groups can really be helpful in hearing other people's stories, realizing that you're not alone, and that learning from others what they may have found to be helpful for themselves. Now, one bit of caution on support groups is we all know that there's a lot of disinformation out there on the internet. So I would caution anyone about just sort of randomly picking a support group. The three that I've listed here are actually also listed on the CDC website. So these are large organizations. They are backed by physicians who understand and are trying to help provide good evidence-based information about COVID and about the post-COVID state. So finishing up today, I'd like to sort of leave you with a couple of key points. The first is to understand that most people fully recover from acute COVID-19 and really don't develop post-COVID symptoms at all. So again, probably somewhere on the order of 70 to 75% of patients do not develop post-COVID. The other point relative to recovery is that in those individuals who have post-COVID, so symptoms that have persisted beyond 12 weeks, most of those symptoms over time we do think will improve and get better. Understand that post-COVID syndrome is really a broad umbrella term, right, which really encompasses a large range of different physical and or mental consequences that are occurring after COVID infection. For most, a detailed history and physical exam with limited testing is really enough to work up COVID. And in fact, most of the time, your primary doctor is well equipped to do the initial workup. Realize that there's no test that can diagnose post-COVID syndrome, but also understand that the lack of abnormal tests doesn't invalidate in any way the existence of post-COVID syndrome or diminish in any way the severity of one's symptoms and the adverse effect it could have on one's quality of life. As far as management goes, conservative management with a limited use of medications is really best practice. And again, I would refer you to many of the sort of self-help exercises and such that one can do themselves that has probably been shown to be most helpful. And then last, just to say that specialty referral is usually not needed, but under the circumstances that I mentioned, there's certainly a role for specialty referral when there's ongoing organ damage that's noted on initial lab testing, if someone is not getting better or getting worse over time, despite conservative management. And then in those scenarios where your primary doctor is just really uncomfortable about an underlying diagnosis, feel that it doesn't quite represent classic post-COVID syndrome, I think that's also a reasonable time that your doctor would likely refer. So here I just have a couple of references. Just the general references is just the Centers for Disease Control and Prevention. The CDC really has some a very good site with good information for both physicians, and there's also many patient-oriented topics that one can find there as well. I've listed here the National Institute of Health Research. This is the main research arm that comes out of the United Kingdom. And I found it to be very helpful. They have some really, really good sort of patient-directed pages and actually patient-directed booklets on living with and understanding post-COVID. And then last, I have the many different links that I've mentioned on self-management. So with that, I will stop and take any questions that you may have and do my best to give you reasonable answers.
Thank you, Dr. Cohen. We have indeed received some questions from participants. The first is, do I need vaccination after having COVID? I was hospitalized and received all the drugs that were given to former President Trump.
Well, great. Well, that is really a fantastic question and one that I hear all the time. So the simple answer is yes. So it is important that everyone get vaccinated, whether they've had COVID or not. It is true that once you have COVID, that your body does generate an immune response for the most part. However, that immune response is probably limited, and the feeling is that it only lasts for a certain period of time. Exactly how long, we don't know, but after about 2-3 months, the immunity conferred from natural infection is probably beginning to wane. And we know that vaccines really provides a much stronger immune response. And for that reason, it's highly recommended. The question mentions that this patient received all the drugs that our former president obtained. One of those would be monoclonal antibodies that we may remember that he received during his illness. And at the time, those were kind of experimental, or they hadn't been fully vetted. But now that's no longer the case. And just this is an opportunity to talk about monoclonal antibodies, because any individual today who were to develop COVID, if they were over 65 or had the chronic conditions that I'd mentioned at the beginning of the talk, would qualify for monoclonal antibodies. And monoclonal antibodies have been shown to decrease the likelihood that someone becomes more acutely ill, requiring hospitalization. So it certainly helped President Trump, and it's really available now for all, assuming that they have some underlying conditions.
Okay, thank you. The next question, what resources are available to help my primary care doctor? Medicare has primary copay at $5 and specialists at $50.
Right. So I guess the point of that question is that, the notion of being sent to a specialist can be expensive. And, your primary care doctor, hopefully they're trying to keep abreast of the literature, as I think most all doctors do. There are some of the resources that I provided today through the CDC or the National Institute of Health Research are all good, places where I think primary care doctors are going to understand COVID and to understand post-COVID. There are also sort of sites, for example, Johns Hopkins has a wonderful website that has a lot of information for physicians on acute and post-COVID. So there are resources out there for your providers to sort of educate themselves. Certainly when it comes to referrals, obviously at UAB, we have our post-COVID clinic, if you will, where our multiple subspecialists as well as primary docs are seeing patients with post-COVID syndrome. So that's certainly a resource as well.
Thank you. The next question is, my son lost smell and taste more than 4 months ago. At what point do you recommend a referral?
Right. So this, before I would necessarily say this patient needs to be referred because it's been 4 months, I think based on what I learned from Dr. Cho, in all honesty, from his talk, was that you really want to give this sort of retraining of your sense of smell, which can be done at home. You don't need a referral to a specialist to do this. You want to give that a trial. And again, I would refer everyone to the link that's attached at the end of my talk where one can see how to do this. Basically, there are 4 different essential oils And it's a process where one is sniffing the essential oils for, X number of minutes, 3 to 4 times a day, really trying to retrain their smell. So I think you would like to give that a trial for probably a minimum of 6 to 8 weeks or maybe even longer. But if one did that and they still weren't improving, then I think certainly referral would potentially be indicated. A few other questions that you would want to ask about that is there ongoing associated headaches? Is the patient having ongoing nosebleeds? Do they have significant congestion that's affecting one nostril versus the other? And if the answer was positive to any of those three questions, that would potentially speak towards other processes going on, again, not just post-COVID related smell issues that would likely warrant referral.
Thank you. I have 2 more questions. The next question is, this participant works out 3 times a week and is having chronic muscle and joint pain and weakness 6 months after having COVID-19. Is this permanent?
That's a great question. One is I feel for that individual because it's really difficult to have ongoing pain, weakness, that far out from COVID. I think what we understand from our understanding of post-COVID now is that most individuals will show improvement. So although I could never say that it's definitely going to resolve, I think most folks will show improvement, and hopefully this patient will get back to, if not their baseline state, close to it.
Thank you. And finally, I had COVID in October. Still nothing tastes the same. I ache all the time and have no energy. My anxiety is out the roof. What should I do?
That's also a wonderful question. And not too dissimilar from the previous question. This is an individual who's having ongoing pain, fatigue, and it seems like really it's significantly adversely affecting their quality of life. You also mentioned the difficulty with smell. So again, I think the answer to my previous question would suggest they try the smell retraining. But another aspect of this question that seems a little different is at least an acknowledgement of the patient's anxiety. And again, it's an opportunity that we don't want to forget, or we need to understand that any individual who's having ongoing chronic illness, that anxiety is a major part of that and can be, and even depression is oftentimes superimposed. So I would encourage this individual to speak to their primary doctor, let them know how they're feeling, also be, honest and open about their sense of anxiety that they are having, because certainly referral for counseling, whether that be through cognitive behavioral therapy, and this could be a case if the anxiety is really severe, where medications might be useful as well. So that would be my recommendation to this individual, would be to reach back out to their doc and see. But don't sweep the anxiety and or depression under the rug. It's important. If left untreated or unaddressed, it can sort of make everything else worse. You kind of get into a kind of a downward spiral, if you will. So that I would hope that would be addressed, which isn't necessarily going to fix all the problems, but might go some way in helping to alleviate some of the symptoms.
Thank you, Dr. Cohen. We're almost out of time. Thank you, everyone, for joining us. We hope this information has been helpful and informative. To watch the previously recorded post-COVID Lunch and Learns, please visit uabmedicine.org/post-COVID.